Hello, everybody. Peter Kas here. Welcome to 5 Minutes to Mastery. We're going to talk about thoracic aortic dissection today, and importantly, the 5 things you need to know to make the diagnosis. Now, I've written a blog on this on resus.com.au. It's also on emcore.com.au. You can have a look. And let's get straight to the 5 things. We'll highlight those. So the first thing is the patient presents with chest pain plus neurology, or chest pain plus vascular symptoms. They're the dead giveaway. The second thing is symptoms occur above and below the diaphragm. The third is the patient may present with syncope as their only complaint. The fourth is that the patient may present with an inferior myocardial infarction. Up to about 5% of inferiors might be caused by a thoracic aortic dissection, dissecting up the right coronary artery. And number 5, I put there sudden severe headache. It can mimic the subarachnoid hemorrhage. So they're the 5 things. And I'm glad I said the word mimic, because thoracic aortic dissection is often called a great mimic because it can look like a subarachnoid, it can look like a myocardial infarct, or it can look like a stroke or a vascular event of the limbs. It has a bimodal distribution. So in the young, it's caused by genetic factors such as Marfan's. In the old, it's caused by intimal issues of the vessels secondary to hypertension. There's about an 80% chance of mortality if it ruptures acutely, and up to about a 2% chance per hour of mortality if it's left untreated for those that survive to come to hospital. The risk factors, well, old, hypertension, third trimester, cocaine use, which raises your blood pressure, previous cardiac surgery, etc. There's a lot more of those. The 5 things, you need to go back and review those again, but chest pain plus neurology, or chest pain plus vascular symptoms. 2, symptoms above and below the diaphragm. 3, the patient with syncope. 4, the patient with inferior infarct. And 5, the patient with sudden onset of headache. So there is a landmark study, and this is the IRAD study, the International Registry of Acute Aortic Dissection. It's in JAMA 2000 by Hogan et al., and it is a landmark study, and you need to read this. And it gives us the signs and symptoms related to thoracic aortic dissection. So chest pain is important, but tearing, ripping, textbook type pain only occurs in about 50% of cases. The important thing is that they do have chest pain. It occurs in about 3/4 of patients. It is abrupt and it is severe, worst pain they've ever had. So sudden pain, severe pain is more important than tearing and ripping. The position of pain is also important, because we find that if the pain is anterior, it usually reflects the ascending aorta. As it moves from the ascending aorta across the arch of the aorta, the pain moves from the chest up and around into the back. And as it moves from the arch down into the descending aorta, it moves down the back. Now, it can go into the renal arteries, causing renal failure, into the artery of Ademkowitz, causing paralysis. It can go into the superior mesenteric artery, causing bowel ischemia. And it can go into the right coronary artery, causing inferior myocardial infarction, and the carotids, presenting a stroke. The examination findings are important. Blood pressure differences between the arms are a fleeting sign. If you've got them, great. But if you don't have it, it doesn't mean anything. A pulse deficit, only 15% of cases. It's important some of them present with hypotension, but aortic regurgitation, the diastolic murmur of aortic regurgitation, presents in about 30% of cases. So that's quite important in our examination. Does a chest X-ray help? Yes, it does. And in fact, most cases of litigation are associated with inferior infarcts being lysed prior to an X-ray being done, and those patients having a thoracic aortic dissection and then decompensating and dying. What do we know about the chest X-ray? There is a wide mediastinum in about 60% of cases, so not all of them. There is a normal mediastinum and aortic contour is in about 21% of cases, and an abnormal aortic contour in about 49% of cases. All up, if you put all these things together, the X-ray is important because in about 80% of cases there'll be either something wrong with the aortic contour or the mediastinum, and that's really, really important. And of course, think of it as sudden headaches, etc. A little word about D-dimers. People have tried to use the D-dimer to rule out dissection. it is, these studies need to be validated. It is not prime time yet, so we cannot do it to rule out dissection. So dissection, we miss it because we don't think of it. And the patient can look deceptively well when they present. But if they've got any of these signs, in fact, some patients are reading the paper with a thoracic dissection. So think of it in syncope. Think of it in sudden headache. Think of it in the patient with an infarct. Think of it in the patient that has all of a sudden developed neurological symptoms with chest pain. And a very good case I had a little while ago was a 72-year-old man called the ambulance because he developed sudden severe onset of central chest pain. When he arrived, he was describing it to the ambulance. By the time he got to us in the emergency department, he couldn't talk. He had an aphasia. So he had chest pain plus neurology. So red flag went up. And this is the other thing. You can do a quick ultrasound of the heart, looking for a pericardial effusion in these patients because they will get an effusion if they dissect backwards into the heart as well. This patient had a pericardial effusion and he had a thoracic aortic dissection of the ascending aorta and went to theatre. So thoracic aortic dissection, think of the 5 most important things and then you hopefully will not miss any of these. See you next time.